Hello, everybody. It's Tuesday night. It's 7 o'clock and we are live. Welcome to V Talks. I'm your host, Veronica Brockwell. Well, tonight's show is going to be a very serious one, but I hope that it helps a lot of people. We had a situation happen here in Massachusetts that really rattled everyone, not only here, but all around the country. On January 24th, there was a 911 call made, and a husband called and said that his wife had attempted suicide. The police came, and what they found in the basement were her 3 children unresponsive. Those children later passed away at the hands of their mother. To say this is a tragedy is an understatement. And what people were saying initially was that she had postpartum depression. So I decided that I wanted to understand what exactly is postpartum depression, postpartum psychosis, and who would be the best people to talk to about that would be our panel of experts. We have 2 wonderful people that are part of our VTalks family that help us with all things mental health. We have nurse practitioners in both adult and psychiatric mental health. We have Brianne Lienkamp. Hello.
Yeah.
And Hannah Chapman.
Hi.
Hi, we're in different order now than we were backstage. Anyway, so happy to have you on the show this evening. I know you are on the V Talks every month now, and we're covering different situations. And we decided, in light of everything that's going on here in our community, that we wanted to talk about postpartum depression. So thank you.
Thanks for
Thank
having
you
us.
for having us. Thank you.
Sure. Real quick, before we dive into our topic, I'd just like for each one of you to tell us a little bit about yourselves. So, Brianne, I'm going to start with you.
Sure. I'm Brianne Lienkamp. I'm an adult and psychiatric nurse practitioner. I'm the owner of Seahorse Behavioral in Marion, Massachusetts. I also teach at UMass Dartmouth, and I'm really happy to be back. I really enjoyed our Galentine's Day affair, and I think I kind of got chills as you were talking about the introduction because there's a lot of suffering in silence, and I'm excited to, be able to help as many women, families, partners that we can with doing the show tonight.
Mm-hmm. And thank you so much. And Hannah, can you tell us a little bit about your background?
Yeah. Hi, everyone. My name is Hannah. I'm a psych nurse practitioner. I work with Brianne at Seahorse Behavioral. I have a special interest in working with young adults and adolescents. I definitely do have a passion in general just for women's health. Ironically, before I started this, I thought about being a midwife, and that just kind of my path just changed. So this is something that I'm super passionate about because it's hard. It's hard to be a woman. It's hard to be a woman with kids, working, having all these responsibilities. So I just hope we can normalize more of this conversation and make people feel like they're a little bit less alone.
Before we get started, I want to read a couple of quotes that I have here from women that have reached out to me. I tried to get women to actually come on the show and share their stories, and many of them were afraid to do it. Mm-hmm. So I'm just going to read a couple little quotes so we can kind of start off and really understand what we're dealing with here. All I did was cry. Why did I have this baby? I felt like I would never be happy again. This other one says, I felt so guilty that I didn't get the proper bonding time with my first daughter. Why aren't I excited? It took months before I could love my daughter in a healthy way, and I had such a headache. All these years later, I still cry about it. I resented this thing, in quotes, that always needed tending to. I no longer had time I also had 2 other children. I wanted to die. What do you say to this?
I mean, I think there's so much that comes from these statements by women that were provided to you. The loss, loss of your independence, loss of your body, loss of time with your other children, loss of time with your partner. So there's this grief and loss component, guilt, because you can't do much for your other children. If you're having a baby in tow, your hormones are completely changed once you give childbirth. And, there is these normal hormonal fluctuations, but if we don't give time to ourselves and know what it is, it really can turn into more of the depression piece, which is really what these women were talking about with these statements. It's more than just the baby blues, the normal hormonal changes that we have that happen within those first few days, that first week. These are situations where these women are beyond that 2-week period, which they're really feeling sadness, guilt. What did I do? Why did I do this?
So let's talk about first postpartum depression. So what is it exactly?
Yeah, well,
Brianne, do you want to take it or him?
Yeah. Go ahead, Brianne.
Yeah, well, a lot of the terminology is changing in terms of what we call postpartum depression. PPD is kind of the abbreviation, but now we're really looking at as the peripartum depression component. So we're really looking at not just we give the birth postpartum, but from the childbearing stages to that first year. So, that's really kind of what we're talking about now with PPD is the spectrum. And maybe Hannah can speak more to the spectrum that we're experiencing that kind of gets looped into this postpartum, peripartum depression.
Yeah, I mean, I think Brianne had mentioned the spectrum in the sense of, there is a distinctive difference between, the baby blues, which happens, up to 70% of women or individuals who give birth experience, some level of like adjustment, right? We call that kind of like an adjustment. We have diagnoses called like adjustment disorder. Basically you've experienced this massive life shift, and that can kind of result in depression or anxiety. But the key is with that is that it lifts, it eventually goes away. The other side of that is, coming into more of like, an issue where it's past that 2-week mark, or, it's getting more into, and I think the thing that we have to remember with what discerns like baby blues or I'm just having problems adjusting versus like real depression is a marked impairment in your functioning. So are your relationships starting to suffer? Are you, I mean, I would hope most people would be able to have time off of work in this immediate, but some people, unfortunately, that is not the case for a lot of people. Is it getting in the way of you working? Is it interfering with your sleep? Basically your just areas of living, is it starting to impact those areas? That's where it starts to get into more of what we would call that more like postpartum depression versus just adjusting to the stressful period in your life.
So let's, do we have a list of symptoms that we could talk about?
Yeah, I mean, similar to like what you would think of as in depression, major depression. What do we see?
Right.
Maybe someone isn't showering every day. Maybe it's been a week. Maybe it's been 2 weeks. It's not part of their day-to-day routine anymore. It doesn't matter. So a lot of like helplessness, hopelessness, as Hannah mentioned. Maybe they're sleeping all day. Maybe they're not sleeping at all. appetite has a decrease or, a change. Maybe people are coping with how they're feeling by eating more and
Or less.
withdrawing.
Yeah.
Well, one of our viewers said she had terrible headaches.
Yeah. I mean, somatic symptoms are very much, and when I say somatic, I mean, physical symptoms that start to show themselves when you're under this incredible amount of distress. That could be, like Brianne said, having an increase in appetite. It can have being a decrease in appetite. It could be, headaches. It could be stomach aches. It could be, that just heavy feeling, that chest tightness. It could be any of those things. I think also one thing I do want to mention too, when we talk about symptoms, it's really, I don't want to say easy, but it's definitely, I think when we all think of depression, we just think of like, I'm going to use the example of like Eeyore, you know what I mean? Like Eeyore.
Yeah, like you're just sort of
right, just kind
sad.
of
Like,
mopey, I'm sad, and that is really not the case. People can be unbelievably high functioning. And so sometimes it's even the smaller things you have to look out for, like I'm not going to see my friends, or if people ask to come over and see me, I'm not allowing people into my house. I'm socially isolating. I'm irritable. I'm getting annoyed really easily. I'm losing my temper. Those are things that you're having trouble concentrating. Like those are things that aren't necessarily like in your face. But those are those like sneaky little symptoms that you have to look out for, or just honestly any change from your baseline, what you're used to being, what your mood usually is, any change.
right.
I think you made a good point about like the debilitating
Yeah.
factor of it. That really is kind of the key from a hormonal shift. I'm adjusting to having this new baby, the family changes. I might be crying all the time, but it's kind of waxing and waning. It's really when someone is debilitated by
Yeah.
what they're feeling that's like the red flag. Hey, something isn't right here. Let's do something about it right now and stop it in its tracks and really get this taken care of.
All right. So, do you guys have statistics of what percentage of women experience postpartum depression?
Yeah, 1 in 7 women, and some of the
What?
statistics
I think it's more than that.
vary. Some
Yes.
say,
Those are the ones
yeah,
that report it.
Right.
yeah.
Exactly.
Hmm.
Yeah. I think it's much
Oh,
higher than that, probably, to tell you the truth.
wow. Yeah. Well, I told you I was trying to, I really did have a lot of people contact me, and they didn't want to,
Yeah.
they just didn't want to come on air and talk
Yeah.
about it. They didn't
Yeah.
want people to judge them.
Yeah. Well, you listen to some of the things that were said, right? I can't even imagine, I haven't been lucky enough to be a parent yet, but I can't imagine having those feelings, you know, towards your own child and the guilt that comes along with that. But it's like so human, you know what I mean? Like it's such to hear that I heard very similar things from all three of those women, like a similar theme of just this overwhelming guilt of I shouldn't feel that way, and I do. And just imagine if you had someone else to come in and say, it's okay. Like
Yeah.
I went through it too, this,
I
you know,
know.
I think we
Exactly.
romanticize like postpartum and pregnancy and bonding to be this like it's beautiful. I got pregnant. I love being pregnant. I'm bonding with my baby. That doesn't happen for a lot of people. It's a it's a huge life transition.
Yeah.
And I think that's true, like the glamorization of the
So
whole
glamorous.
process. Like it's not glamorous, you don't feel good. If you've had a
Right.
C-section or you've had a vaginal birth, like
Right.
it's not a pretty picture.
Yeah.
And we're not talking about the components of anxiety today, but 17% of women also, and probably higher numbers there, experience the coexisting anxiety with depression. And if you have underlying anxiety, obsessive compulsive features, guess what? Like, in addition to you not feeling well and not sleeping and potentially having depressive symptoms, add in the postpartum bipolar, add in the postpartum PTSD. These might be situations where someone had a non-traumatic birth. Think about someone who had a traumatic birth.
Oh, sure.
No,
Yeah, of course.
it is like, I agree with you 100% that I think the statistics probably are higher than what we see, but that's pretty significant. And I mean, I'm sure you could count, 7 of your friends and say, like, one of us, this is real, and
Yep.
it has happened to friends and family.
Mhm.
So let's talk about specifically for postpartum depression, treatment options.
Yeah. I mean, Brianne, you want me to comment
Sure.
on this one? So yeah, I mean,
I never know who to ask.
No, that's okay.
sometimes.
We like tag
Yeah,
team.
you
It's like a
guys
relay
should.
race.
Yeah, good.
To Brianne's point earlier, there's of course a wide range of depression, right? Just like we see when we work with patients, sometimes that can be taken care of with just having that support of therapy. Psychotherapy is amazing. And it's just having that space and that time to come in and talk about how you're feeling and build on your skills to learn how to cope with these situations that you're struggling with, being a new parent or a repeat, uses your, just learning how to be a parent of multiple children and a newborn, or how to deal with that, I should say. So there's therapy all the way to, of course, medication management. I think there's a place for all of that. And typically, I want to just say it depends on the patient, but a first line would be something like an antidepressant, and that relies heavily on the individual patient. What is their family history? Is there a psych history aside from them just going through this? Because oftentimes that is not usually the first presentation of some issues with depression and anxiety. It can be. So those treatment options, I think, just vary based on the individual. I don't know if Brianne, you have anything to add to that.
Yeah, I mean, I think you make a good point with some of the risk factors that influence the treatment options. So there's a lot of risk factors. As Hannah mentioned, someone who's had depression in the past, maybe someone who has a trauma history, but also a young pregnancy,
Yeah.
a pregnancy that maybe, as we talked about, was traumatic, that there's financial burdens that are there, a family history. Maybe mom had a postpartum depression. Mood disorders are huge, huge. If someone has had a family history of a mood disorder, schizophrenia, bipolar, just maybe even this chronic dysthymia, Eeyore type of mood component, then that's going to impact the treatment options because they're going to be more higher risk.
Right.
And we do use the same medications that we use for depression and adjustment disorders, with the serotonin-based medications, the SSRIs, SNRIs, mood stabilizers, psychotherapy. I mean, we have new advancements with this type of depression with brexanolone, which is a injectable that is given over a couple of days. And it was really created to target a postpartum, peripartum depression. Also, we see ECT being utilized and TMS and even our S-ketamine. So there's choices for treatments. It's just doing the right treatment for the right time for the right person.
Right.
I have a viewer that just popped in. Mary Cronin said, "Don't forget about the amount of pressure that is put on to meet certain criteria to be a mother. I have heard giving birth via C-section wasn't considered birth, or that you're less than if you can't or do not choose to breastfeed."
Yeah.
Thoughts?
Oh, that's like speaking to my soul. I 100% agree with Mary. And I think that first and foremost, I just want to say that no matter what, method of delivery, it is hard to give birth. It is hard to have a baby. One form is not more valid than the other. C-sections are major abdominal surgery. I think
Sure.
some people don't realize that. I've been lucky enough to see like 8 or 9 of them. And I was actually a little horrified when I was like, this is a lot. You're
Yeah.
talking a 6-week recovery, 4 to 6 week recovery, no lifting heavy, anything over 10 to 15 pounds. But then I think I really appreciate Mary bringing up this. I think the breastfeeding conversation comes up a lot. And I will say this as someone that worked in the hospital and was able to do my internship in nursing school on a postpartum unit. You hear the term all the time, right? We hear breast is best. We hear it all the time. And it's a great, there are so many wonderful benefits to that. And sometimes it just doesn't happen for a number of reasons. And I have actually seen women that I know get so overwhelmed with breastfeeding that I swear that alone was the thing that triggered them into having severe anxiety, depression, because it's this idea of I'm a failure. I have failed my
Oh,
child.
that makes
I
me
have
want to cry.
right? It is
Oh my God.
heartbreaking. And honestly, I don't know whoever is listening, but I think this kind of comes back on us as healthcare providers because we're the
Yeah.
ones that start this conversation of my thing is that I used to say, and I used to teach this to even like my little nursing students, fed is best. Fed is best. If your baby is eating and being fed, that's the best, right?
You
So,
win.
but I think Mary's
Yeah.
so right. And it
Yeah.
kind of goes back to what we were talking about, this glamorizing of, motherhood. And there shouldn't be any expectations on that. Everyone is going to do whatever you feel is best for your baby and your family. I'm going to most of the time trust that that's how it should be
Yeah.
because, you know, that's kind of what you do. You're a mom. You make those decisions and you should be supported in those decisions.
And
So
sometimes
I
you
have a
make the
question
choice.
regarding
Right.
breastfeeding.
Yeah,
Um, how do some of these medications
that's a great question.
affect the breast milk?
Yeah, some you can't use.
Right.
When
Okay.
we talk about treatment
Yeah.
options, some
Mhm.
are off the table.
Yeah.
Some come with a risk. And, some women are fortunate enough to be able to pick and choose with their providers what they can take.
Right.
And unfortunately, there is women that can't, that
Mhm.
some of these first line agents are not safe for
Yeah.
someone who maybe has a bipolar disorder, schizophrenia. It's just, you could make the situation a heck of a lot worse. And, when we talk about postpartum psychosis, next we'll kind of talk about
Mm.
why that's the case. So
Right.
it's the risk versus the
Right.
benefit. It's trying to treat the mood to the best capability that you have with the least amount of risks possible, but weighing it out and just being honest that,
Yeah.
hey, maybe this could put your baby at risk for
Mhm.
low birth weight.
Right.
Hey, maybe this could put your baby at risk for some changes in their respiratory status.
Mhm.
There's been talk about ADHD, autism, how some of these medications can potentially have longer term consequences. But, you have to make the right decision at that moment in
Right.
time. And, it's just like with being fed, it's just being fed. And it's the same thing here is we want you to be safe and we
Right.
want you to enjoy this time with your newborn and maybe your other children. And it's whatever's the best at
Yeah.
that moment in time, putting all the risks on the table and the
Yeah.
benefits and making a medical sound decision from that information with your patient, with their family, with, it's not dictating what it is.
And if I could just,
So, yeah,
can I
go
just add
ahead.
one quick
Yeah,
thing? Something
sure.
I just think all people should just be aware of as well is, you know, when it comes to medications, you know, healthy mom, healthy. I always say healthy mom, healthy baby. If mom is doing well, baby will usually follow suit, right? And something just to keep in mind with these medications is, you know, because of obviously the ethical situation, we don't do studies on pregnant women. We can't do studies on pregnant women because there's way too much risk associated with that. And so all of the data that we have, and I think, and I'm only mentioning this because, you know, I see a lot of people that are hesitant to even consider meds when it might actually be really helpful, because of course, there's always going to be a risk benefit discussion. We can't do studies on pregnant women. So all of the information we have is what we call retrospective data, where we're looking back at a pool of patients and saying, okay, 1,000 women took, you know, Zoloft during their pregnancy. And these are the trends that we've seen. You know, we didn't say like, here's 100 women, we're going to give you guys
I
Zoloft
know.
and we're not going to give the other 100 Zoloft and let's see what happens. So that's something to keep in mind too. At least for me, I kind of feel like, you know, that it's helpful in the sense of like, okay, well, you know, overall, like they're getting rid of pregnancy classes for medications. You know, there's definitely, it really at the end of the day comes back to what Brianne said, which is it's a risk benefit conversation. And whatever decision you make, you know, just to go back to Mary's point, that shouldn't be judged either, because some women, you know, some people don't have they're in a position where maybe this is the only choice that they have.
Well, and let's just talk about why it's so important.
Yeah.
Healthy mom, healthy baby. We're now going to talk about postpartum psychosis.
Mhm.
And I'd like to talk a little bit about the case that's going on here right now. We all have limited information, obviously. But what are your thoughts on our mom from Duxbury who attempted to take her own life? And she had a psychotic, we think, episode with her children, which ended their lives.
I mean,
Brianne, what?
it's a very rare occurrence. You know, I want
Yeah.
to start out by saying that, you know, it's a
Mhm.
rare occurrence. 1 to 2 out of 1,000 women end up with this diagnosis. And, you know, and I also want to say there's help for it. And we're living in a time right now where there's lack of mental health providers. There is visits that are going on via text message in mental health. I mean, we've seen companies make millions of dollars by offering, come get psychiatric help for this much money per month. We'll send you medications in the mail. Call it a day.
Are you kidding me?
I
No.
am not kidding you.
No.
I am
In this
not kidding you.
in this country?
Yes.
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 Yes. You're probably getting, take a look at your Facebook ads. Everyone is
Well,
probably.
I know what I'm going to get now.
Yeah.
Because
Yeah.
we've had this show.
Yeah.
Because they're listening.
Yep. Take a look at that. So we have this picture.
So like auto ship of
Yeah.
of what?
Lexapro,
Ativan,
Wellbutrin.
Mhm.
It used to be
No.
the controlled, which
Adderall.
from May, there's going to be the requirement to have face-to-face visits again. You
Oh,
can get
okay.
ketamine offline.
Mhm.
You can get
And
whatever
it
you want.
and we're
Prescribed.
sure that it's prescribed and
Yes.
it's
Yes,
legitimate.
by a prescriber.
Yep.
So someone is prescribing these medications like Hannah or I to someone they don't know, sending the medications to their home and potentially following up with them or not. We've heard of many situations where they've kind of been ghosted by the prescriber once the medications have been ordered. And
Oh no.
yeah, but this is
So now
happen.
you're used to it and then you can't get it.
Mm-hmm.
So this is a real thing. So even in the state of Massachusetts, we have nurses who are part of healthcare systems, and Mass General has an amazing reproductive psychiatry,
Mhm.
perinatal psychiatry program that, we have these programs, but it's like we don't have enough providers. We
Yeah.
have waiting lists. We have difficulties with getting people into psychotherapy and non-medication management options. So with this case, I think that's part of it that just makes me really sad, is that we don't know the circumstances
Mm-hmm.
of where the disconnect in the healthcare line was. And the other point to make is when someone is having psychotic features, which can happen if you have bipolar, schizophrenia, severe depression,
Yeah.
can lead to psychotic features, is that people can seemingly function. They come into our office, they drive themselves here, they drive themselves home, and there's an altered reality that can be present. That it might be the little things that we see, like someone coming in and like sniffing hand sanitizer and having some paranoia, but they're out driving their car, they're going to the grocery store, they're going back home. So, there's the spectrum again of how people are dealing with the symptoms
Yeah.
that they're having.
Yeah.
So in this particular case, what I have read is that it was premeditated. Is that a possibility with a psychosis?
I mean, Brianne
With
said it.
a psychosis, maybe not hers, but have you
Yeah.
heard of?
So again, like, we're speaking on, just our knowledge of having, worked with patients that, have been in psychosis. It's, to Brianne's point, an altered state of reality. Can psychosis impair your ability to make sound decisions? Yes.
Mhm.
I'm going to use an example of when I used to work in the hospital, and we would have patients that would have surgery, and your risk of having any sort of like post-op delirium is really high after surgery. And I remember we were doing a training on delirium, and because it can be you can end up permanently delirious. That's a thing that can happen after surgery. And so I
I did
remember
not know that.
yeah, there's a lot of things. Yep. So so I remember they talked to us about this gentleman who had surgery, very young, like robust guy. He appeared completely with it. Like, hi, how you doing? Oh, okay, you want me to take my meds? No problem. Later, after he discharged and came back for a post-op appointment, basically told them that he was full-blown paranoid. This was a person I believe might have worked in law enforcement, so kind of had this background of knowing how to like be like sneaky and just kind of fake it till you make it in stressful situations, and told the provider that they were convinced that every single one of us that was walking into their room was trying to kill them, and that they just basically did whatever we said because in their mind we were holding them hostage and we were going to murder them. This was a 40-something-year-old, I don't know exactly how old, very healthy, looked completely normal. And in this person's mind, this was the narrative that was going on. And not just a narrative, this was his reality.
Yeah.
That was his reality. And we had no idea. This
And
person got
how long was this going on?
Well,
With
again,
him?
this was just like a story that we were told when we were learning in a class about
Oh,
delirium.
okay.
I think, but delirium can last.
Yeah.
There's so many levels of this, the brain is the most complicated organ. It does we understand it and we don't. There's so much we know and so much we don't know. And when your body and your system is under duress, your brain has an amazing capability to do things that are there to weirdly protect you and like basically dissociate. Like, I'm just going to remove myself from this reality because it's too overwhelming. And unfortunately, sometimes that turns out into these situations that are really scary, but it absolutely can. And honestly, like, just to piggyback off of what Brianne was saying, like, I find that whole situation just like absolutely heart-wrenching. The first time I heard about it, I was devastated for everybody. And obviously we don't know the whole situation. We've also heard of things in the media of other situations, you know, the Andrea Yates case that happened years ago. And I just hope that people can just have compassion, because it can happen to anybody. And I think that's sometimes why people have such strong emotions about some of this stuff, because it's terrifying to think that someone who really seemed to just be a lovely individual, a nurse,
And I heard a good mom
a
with
wonderful
her,
mother,
with her
a
kids.
wonderful wife. When people see that, I think our defense goes up. And that's where we don't want to understand it, because if we do understand it, that means that we're accepting that this is a reality for any of us. And that's scary. But it's important that we accept that this is reality so that we can put things in place to help so that this doesn't have to happen, because it doesn't.
Yeah, there's hardly any education
No.
for psychiatric nurse practitioners. I'm an adult nurse practitioner. I gave birth by myself.
Yeah.
Basically, the nurses left me and were like, "You're a nurse, you're good to go," with my first daughter. And I didn't know how to breastfeed. I didn't know anything about the mood. It was, and this is still to today. My
Oh, yeah.
daughter is 16 years old, and this is still the education that we're giving
Yeah.
to our nurses, who are the front line, who are
Yeah.
doing the education. And it's a scary time, and I think that that's true. This could be any one of us that are put in this situation. And it's not just the mothers,
Yep.
fathers, caregivers, partners, they too can develop
Yep.
depression during this time. There's a lot, it's a lot. There's a lot that gets put on the plate here, and the finances, your sleep patterns, it could happen to anybody. And that's the reality. And we, like I said, we have had patients come in here and who are acutely psychotic, drive here, come through and say, I could jump off that building.
Yeah. I can fly.
I could fly. And okay, but you were working with kids earlier in your day job. That's your day job. You're working in childcare, and like, you're giving me this information, perfectly functioning. Like I said, driving, childcare, carting the kids from here to there, but then saying, this is the reality, is that I could do that. I could jump off the building, no problem. I can fly.
Really?
Yeah.
Mhm.
Yeah.
So,
It's
when
a
we
real
when we
thing.
look at the situation, is it because she was trying to protect her kids? Like, maybe she
Right.
was trying to
In her
say, if
reality.
I can put these things in order, and that I'm saving them from maybe the devil or the demons or whatever it is, that was on repeat in her mind, that was her reality, that maybe she was hearing voices, seeing things, the paranoia. But you know we don't know enough about the situation. We weren't in her brain to say that this is what it was. But that's a common phenomenon. It's just, I'm saving my children from what is really in my mind that I need to save myself from as
Yeah.
well.
The threat. Yeah.
So, do you find that people go from depression to psychosis, or do you find it's typically one or the other?
Well,
Because there is,
yeah.
it sounds like there's a marked difference
Oh,
between depression
Yes.
and a full-blown psychosis
Yes.
where you're in an altered state of reality versus
Yes.
I'm feeling sad, I haven't
Yeah.
showered for a few
Yeah.
days, or, or I don't want to get out of bed.
Yeah.
That seems very different than
Oh,
thinking
yeah.
that you could jump off a building,
Yeah.
you
I
know?
mean, it's so individual. I mean,
Mm.
for some people, it's just something it just snaps. You know what I mean? I would say, and I don't know if Brianne, what your thoughts are on it, but my kind of thought would be, more of like, if you just end up in this like kind of situation where you're just what we call like treatment resistant, we're trying to treat the depression, it's not lifting, it's not lifting, it's not lifting, it's not lifting, and it just gets to the point where that depression is so deep um that you can develop psychotic symptoms. Again, I don't want to say this for sure, but I have seen this happen in the hospital with women who are not that far out of their postpartum, like from having their child. We're talking like days. So in other situations, I do think it can be more of I just think it's different, like more of that
Mhm.
flipping of a switch. I think it's just different for everybody.
Well, like you have the highest level of hormones in your body
Yeah,
during the
right.
pregnancy, you deliver, and now like bam, like you have
It's
this
gone.
huge down spike in the hormone levels. So that's thought to be a trigger. But then you also have people who have bipolar schizophrenia who maybe it wasn't a depression, maybe it was a medication that they were given, maybe it was the hormonal fluctuation that you can go from. One of my patients with postpartum, perinatal was doing fine, really like weeks went by, kind of like, yeah, I'm just trying to navigate this. Went into a manic phase. She wasn't sleeping. Went completely manic. She called me. She was walking over the bridge. Left the kids at home. I don't really care anymore. I don't need to do this anymore.
Thank God she
And
called.
yeah, and I said, "You're okay. What can I do for you? Like, you're not sleeping, you're completely overwhelmed. What can we do?" So, we were able to at least stabilize the mood, but what goes up will come down. And now we're dealing with this massive depression with suicidal ideation. And I just now I can't live because I can't do this. So, it's not always like depression to psychosis. Sometimes it's manic to psychosis
Hmm.
to depression. And, that's the point of not doing a 5-minute visit, not doing an online visit is I had a relationship with this person that they felt comfortable enough to call me to say, This is, I'm not thinking right.
Yeah.
Like, this isn't me. I
Mhm.
don't know what it is. I don't know why I'm doing this, but I'm compelled to be walking the streets right now and crossing this bridge. And I don't know where I'm going. And I don't care that I'm alone. And I don't care that this isn't safe for me to do, but was able to reach out to say, like, help me, guide me. And now like she's doing amazing, like amazing.
I'm
And
so glad to hear.
it's just, but you can see how it's just so, important that with just a flip of the switch, that could have not been amazing.
Hmm.
And it could have been bad. And, it's listening, it's communicating, it's having a relationship with our patients,
Yeah.
which I feel like we don't have the opportunity to do that for so many reasons: lack of staffing, the insurance dictates the cost structure. So, you have to see so many people in a day. And, I think if that cycle can shift and we can spend the time we need to spend and have reimbursement for the time that's warranted that we're spending,
Mm.
that we can save lives and we can make a difference because we do it every day.
Yeah.
Of course. Now, with a psychosis, you may not know you're in psychosis because you're in an altered state.
Hmm.
So, what should people around like what types of things should they look for, especially if the person in psychosis is trying to hide the
Yeah.
psychosis? There's got, like, are
Yeah.
there any things that you should look for?
Well, like Brianne said, it could be, the little nuanced comments of, um, oh, you know what, I'm just going to put my phone over here because I'm pretty sure that, like, the government is listening to our conversation right now. Anyways, what's for dinner? You know what I mean? Like those little things that you're like, what did you just say? Like,
Right.
again, the signs that you're not based in reality, right? Um, it- it's hard. Like, and that's the scary part, is sometimes it's just not that obvious thing. But, again, like some of those other little signs, right? Like the paranoid things, like um maybe this person is like avoiding any social interactions, or it can be those like little signs like that as well.
Mhm.
But I
It's,
would
yeah,
say
like a
right, I
change
would
in the
just say a change
behavior.
in what and remember, if someone's getting better, they should start to seem more like themselves. And again, there's a difference between I'm functioning and I'm back to being me, and again, I can't comment on this local case because I don't know the ins and outs of it. This is just me, saying for those of us in just general situations like that. It sounds kind of like, you know, um silly, but that spark of that person that is there. Like, is that back? We see that all the time with our clients. People will say like, I have my daughter back, like that, I have my person
Oh,
back. Like sometimes you just,
yeah.
you know what I mean? It's hard to
Mhm.
even put that into telling to like, oh, what exactly should I look for? But sometimes it's just that gut instinct of like, okay, you're back. Like I have you back. This is the person that I know. Um, and sometimes it's as simple as that, of just and listening to your own gut. If you have a loved one and you just know like it's still not where it should be, pushing to see if there's to really figure out if there's anything else that can be done.
And again, treatment options. We've gone over some of these things. Seek help,
Yeah,
Yeah.
that's the big one.
right? Seek
Yeah,
help. And what does that mean? It means reach out to family and friends. I probably, from what you're saying, it's very difficult to see a therapist right now.
it is. Yeah, and I'd also like to
So
mention,
what
oh, sorry.
so yeah, so what should someone do if what's
Yeah.
the first thing they should do?
Well, remember, women, we do, and individuals do have this is why I'm glad that, you have OBGYNs, right? You have your
Mhm.
OBGYN office. Pediatricians, I think, are also doing the work as well of screening parents at these appointments when you're bringing in your newborn. So it doesn't just have to be a therapist. It could be, just letting your OBGYN know, like, and oftentimes they, or even your work, like, sometimes depending on where you work, there's employee assistance programs. I know a lot of hospitals and bigger companies have stuff like that as well. Um, so it could, whatever basically face to face provider you're seeing, someone can help you, someone can get you into contact with who you need to see. Um, and there's groups, like sometimes there's groups or, different things like that you can join to, like support groups.
Mhm.
And this is new. The Mass Behavioral Hotline is new this year. It came out after the Suicide Hotline 988. This is 24/7. So if you are in a situation where you are having difficulty getting help, maybe it's not at the crisis level, emergency room level, but you're not sure. Maybe you are and you're just not sure that you're at
Yeah.
that level, that that's these are hotlines that are there to help, crisis lines that are there to help. And they're trained professionals, and we're lucky in the state of Massachusetts to have the behavioral helpline. There's resources for maybe substance abuse use
Mhm.
with this partum period too, during a pregnancy, and that can be another trigger for psychosis if you're using substances. And even with, I mentioned the Mass General Reproductive Psychiatry, PPD, um, clinics that are there, and those are resources to help providers as well. So we can we can do a consult, we can put in the information online, and they'll get back to us. And so we have resources that we can use. It's just being savvy to navigate them. And and there are certainly some practices that if you call and you say, like, this is where I'm at, I really need help today, that there are some practices that will squeeze you in. And they understand that the situation that can change so quickly with a particular postpartum, peripartum situation.
It will be interesting to see how this case unfolds. Surprisingly, many people are rallying around this mother.
I hope they
and
do,
and I think there's a reason, because there's a relatability there.
Yeah.
And her injuries are life altering. She will never be the same.
No.
And it's just so tragic, the whole situation. But it did bring postpartum depression and psychosis to the forefront, and maybe more people will get help, because it certainly rattled our community.
Yeah.
I think it will. One of my students, like, it was her first day today at our practice, and she's doing a doctor of nurse practitioner program. She works in the ER, and that's going to be her project, is making sure posters are up, education's put into the packets of information that go home with women. It's really, something that she really took to as well, and just really put her mind to thinking, like, what can I do?
Yeah.
Like, what can I do as an individual? And I think you did the same thing by having this discussion today, is what can I do as an individual? And from Hannah and I perspective, it's I've done, like, women's health, the reproductive courses, and trying to just learn more about this topic to be best able to handle the situation if we get whatever spectrum comes our way. So I think that's 4 of us that really are just motivated, and hopefully people watching will take this, and they'll be motivated to learn more too.
Just on that, this is interesting. And I don't even know if you know this, but I have a farm, and sometimes we'll have, little baby pigs, or we don't, they're pets that, we don't eat them. I have to say that. I don't even eat meat. So yeah, but every once in a while we'll get, an animal that rejects the baby or the babies. And there's nothing we can do. The mother's like, I'm all set. I don't really care. And, we have to take over at that point. As a matter of fact, I had a little baby. I nursed a couple baby goats, little, they're very cute.
So cute.
But that's not ideal, right? You would prefer to have the mother take care of the goat. But I mean, I think it happens with animals too, right?
Of course. Yeah.
So I mean, it's a real thing. It's where they, for whatever reason, it's the same thing. They reject the baby.
Right.
And so it must be a similar hormonal situation that happens.
Yeah. And I want to say too, like, just with what Brianne was saying about, like, resources and how can you help, and, not to get like super serious, but this is why I think it's important for, we have to use our voices. You know what I mean? We have a duty to one another to, this is why it's important to, like, talk to your local representatives about, like, what is this healthcare like available in this area. One thing that I want to just say with the Lindsay Clancy case is that, she did have some presentations to local places that are really, really well-respected psychiatric facilities. But I can tell you, and Brianne can tell you, that from our experience, they're overworked too. They're understaffed. There's not enough resources for the providers. When I tell you, I just spoke to someone today whose child sat in the emergency room for 3 days after having a near
Oh,
suicide attempt, and and wasn't even able to find a bed. The bed was found in the middle of the state, and this
yeah,
person isn't even able to drive there. So this is the reality of what we're
I
dealing
know.
with out here. So,
I know.
it has to start. Yes, I mean, it just goes so much deeper than just
Mm,
this particular situation. Unfortunately, I think speaks to the state of what is going on out there in psych, which is that
yeah,
we need more support so that you, the patient, can get more support, because this is unfortunate. It's honestly a perfect storm when you are coming off the heels of a pandemic where people are, and that's another thing. She was a nurse. She worked through a pandemic.
I know.
I was in the hospitals during the pandemic too.
Yeah,
We all have a collective trauma from what we experienced in 2020. And it just, it was, we're seeing it now. There's all of this backlogged mental health stuff that's just all coming out of the woodwork from everything we've experienced over the last 3 years. You couple that with a massive demand for mental health and not enough providers,
right.
and it's a tough situation.
And a cocktail of medications that who
Maybe
knows if
wasn't
you're
helpful.
being
Yeah.
monitored the way you need to
Right.
be to
Yeah.
notice the
Right.
changes. And
I
you know,
believe the baby was 7 months old,
I think, yeah. I think
something like
around there.
that.
Yeah.
And so she had been dealing with this for a bit of time.
Yeah. Yeah.
So, and from what we know, and we only know what the media has given us at this point, she was on quite a bit of different medications. So for a long time,
Yeah. Well, she
and
was
they
trying. She
she
was
was
trying.
trying.
It shows that this is someone who wanted to get
Yeah.
better, and I can't comment on, we can't comment on the medications and stuff because, of course, I don't know the ins and outs of the situation. But,
Mm-mm.
med management can be really challenging for a number of reasons. Unfortunately, it's not always, here's the first medication we give you and it's going to work. And we
Sure.
do know that the more meds we try, oftentimes the less likely it is that you're going to respond to those meds. And that's just what the science and the research shows. So it's a tough,
yeah.
it's a tough thing to figure out.
Yeah, but again, if you know your patient and you spend the time, you're not adding a bed to fix a symptom, to fix
Right.
another symptom, to
Right.
fix a symptom, to fix a symptom. And, and I think we don't know when the course of these medications were given that she was on, but I mean, I think our jaws dropped, when we saw the med list, and I just want to say that, it's more.
Well, that was the first thing I asked you,
Yeah.
because when we were talking about the show, I'm like, is this typical?
Well,
From
unfortunately, it is. Like,
yes.
we see, like, certain
Well,
providers.
yeah, as you said, you can go
Yeah.
online.
Yeah.
I'm going to see it on my Facebook feed,
Yeah.
and I can hit my Bitly link, and I can get whatever I want, right?
Mhm.
Yeah, and we see it.
Yeah.
We get people coming to us all the time on several medications, and we just try to peel back, and it's
Yeah.
communication. Know your patient. If you're getting a 5-minute visit, you're not getting
You're
good
not
care.
getting good
You're
care.
getting a
Yep.
15-minute visit, you're still
You're
not getting good care.
Yeah.
And
Advocate for
that's the
yourself.
problem.
Advocate for
You know,
yourself.
I really wish that it was required, just like you're supposed to get a mammogram once a month,
Yeah.
once a year, that we should be required to get a mental health check.
I
No,
know.
I do.
No, I know. I agree.
I wish that was a possibility. I think we'd all be a lot better off.
Yeah.
It would prevent a lot of things.
Yeah.
I agree.
So anyway, I guess we're coming up on the hour, ladies.
Thank
I know.
you, Lee.
I'm so sad.
I know. It always goes by so fast.
I know it does.
It's true.
I feel like we could do this in gosh, there's so many more things that we could just keep going with this, but
Yes. So we're going to close out the show tonight, and then we'll be back next month.
Sounds great.
So we'll come up with another topic. I love spending time with you. Thank you so much.
Same.
And you're so helpful. And
So are you.
oh, well,
You are.
I just listen.
But you're giving people a
Yeah.
platform, and that's priceless. So
Yeah. Well, thank you. That's the goal. So we're going to heal together.
yes, we are.
Perfect.
All right, ladies. Thank you so much.
Bye,
Thank
everyone.
you.
All right.
Everybody have a good night.
You too.
Bye.
All right. Bye, Hannah. All right, everybody. Thank you so much for tuning in to V Talks on our show on postpartum depression and psychosis. I've got the suicide hotline here called 988. If you have any feelings at all that you need to speak with somebody, they are there 24 hours a day, 7 days a week. We will be back next Tuesday night with our favorite doctor, Dr. Michael Wild, and he will help us with our functional medicine health. And I always look forward to seeing him and his dog, Ralphie. So he will be here next week at 7 o'clock live. Thank you so much, and we'll see you next Tuesday night. Bye.